Hello. Welcome to another session of Zooming through ID with Dr. Gopal. Those who don't know me, I am Dr. Indulekha Gopal. I did my fellowship at Duke University, and I've been practicing for almost 20 years. Since 2005, I've been practicing. Uh, Teaching residents is one of the most rewarding parts of my work, and I am very passionate about it. And I'm proud to say that I'm the assistant program director for our ID fellowship program. So when internal medicine residents, when any resident, when they rotate with me, I give them a specific topic so that they can do extensive research, and then they do present their finding in this session. And I think that is the best way to learn. And the topic today is hepatitis. And we have Dr. Lean Dagger. She's going to present that. Lean did the elective rotation with me, and she's excellent and she's very enthusiastic. And I will let her, without any further ado, Lean, you're ready? Yeah?
Yes, I'm ready. Hello, my name is Linda Gare. I'm first-year internal medicine resident at Broward Health North. And today I will have the lecture about viral hepatitis. So let's start. Just waiting for the PowerPoints to open. All right, here you go. Okay, I'm just gonna. All right.
Okay.
Yes. So our topic today is about viral hepatitis. There are different viruses that causes hepatitis. Let's start with the first one, which is hepatitis E. So hepatitis A, I'm sorry. Hepatitis A, it's an RNA virus from Picorona family, spread through fecal oral route, does not lead to a chronic infection, and usually has no complications. The liver usually heals from hepatitis A within several months. It's often encountered in developing countries with a poor sanitation and increased risk of fecal oral spread. In the United States, we have about 24,900 new hepatitis A infection diagnosed every year. Most common risk factors is contracting hepatitis A is international travel. So for hepatitis A, incubation is about 4 weeks. Symptoms are similar to gastroenteritis or viral respiratory infection, including symptoms of fatigue, nausea, vomiting, fever, jaundice, anorexia, and dark urine. Spontaneous recovery in most patients is expected. Acute infection, how we test for hepatitis A acute infection, we look for immunoglobulin IgM antibodies and the presence of IgG antibodies. That means that the patient has been infected and in the past, and he has immunity lifelong against hepatitis A infection. Hepatitis B is a small circular, partially double-stranded DNA virus. Hepatitis B virus is known to have 8 genotype variant, and it's transmitted parentally and sexually when individuals come into contact with the mucous membrane or body fluids of infected individuals. Hepatitis B virus is leading cause of chronic hepatitis, liver cirrhosis, and hepatocellular carcinoma worldwide. The risk factor infection is higher in the countries where the prevalence of chronic hepatitis B infection is more than 2%, such as Western Pacific and African regions. About 1/3 of the world's population has had infection of hepatitis B virus, and about 5% of the population remain carriers. Now, about 25% of these carriers develop chronic hepatitis, liver cirrhosis, and hepatocellular carcinoma. The documented number of global death annually from hepatitis B infection is about 780,000. In the United States, we have about 22,600 new infections diagnosed in 2018, and it's estimated to be 862,000 people have chronic hepatitis B infection in the United States. So the median prevalence of the infection in the United States is about 0.4%. So who are the people at risk of contracting hepatitis B infection? People who use drugs, intravenous drugs, or who have sex men with men, or healthcare workers, prisoners, partners to hepatitis B carriers, people who have multiple sexual partners, or people in the endemic areas. Also can be transmitted from mom to babies. We have about 70% to 90% chance that the infants chance of infection to mom who are positive for hepatitis B antigens, and up to 90% of those who become infected, of the babies who become infected, will develop a chronic infection. According to American Association for the Study of Liver Disease, the American College of Physicians, and United States Centers of Disease Control and Preventions, and the World Health Organization, we have multiple tests to screen for hepatitis B infections. Individuals without a known risk for hepatitis B infection, persons above 18 years old, should be screened for hepatitis B infection at least once in their lifetime, unless there is a documentation of the vaccine as well as the serologic evidence of immunity. Now, for pregnant persons should be screened during each pregnancy, preferably in the first trimester, regardless of the vaccination or the history of testing. Individuals with risk factors, such as people born in countries with the hepatitis B prevalence, Africa and Western Pacific, should be screened, even with those who have a prior documentation of vaccination. Testing, the first serum marker to appear in patients with acute hepatitis B infection is the hepatitis B surface antigen. This antigen indicates that the patient has hepatitis B viremia, but it does not differentiate between acute and chronic. The first antibody to appear is IgM antibodies to hepatitis B core antigen. After a few weeks, IgM antibody core disappear and IgG antibody core becomes detected, which usually remains present for life. Now, this is the table that summarize all the testings and what each one, combination of the results that indicates. So if a person has a hepatitis surface positive and a hepatitis core antibody positive, but hepatitis surface antibody negative, this is a chronic hepatitis B. If the patient has positive for core antibodies and positive for surface antibodies, but he doesn't have surface antigen, this is past hepatitis B infection and it's resolved. In patients who have only core antibodies positive, this is past, resolved, or false positive. Patient who is immune will have only anti-surface hepatitis B antibodies, and the one who is uninfected will not have any of them positive.
So this is a very important slide, and this is good that you're saying it is. It's a testable point. Sometimes in some form, they will ask this. And regarding the hepatitis A, one point to emphasize is it does not go into the chronic phase. The one other point to emphasis on hepatitis A would be the hepatitis A vaccine is very effective. So they may give a test question where they will say clinical scenario consistent with acute hepatitis, and they may say that the patient did get one dose of vaccine, and then there will be other choices. So even if it is one dose of hepatitis A vaccine, it is still, it is effective. So we have to look for other causes in that scenario. And worldwide, acute hepatitis, hepatitis A is very common in certain, developing countries and everything. For travelers, the vaccination is important. Yeah.
Yeah.
Mm-hmm.
So in some patients with hepatitis B infection, the hepatitis B surface might not be detectable until the window period of several weeks to months. So during which neither hepatitis B surface antigen nor hepatitis B surface antibodies can be detected. So at this time, we can do the serologic diagnosis may be made by detection of IgM antibodies against hepatitis B core antigens. Anti-hepatitis core can be detected throughout the course of hepatitis B infection, and the hepatitis B antigen and antibodies is marker for hepatitis B replication and infectivity. The person with hepatitis B antigen is usually associated with the higher level of hepatitis B DNA in serum and higher rates of transmission of hepatitis B infection. So the clinical presentation incubation period for hepatitis B infection is about 12 weeks. Initial clinical symptoms could be anorexia, malaise, and fatigue. Small percentage may develop fever, arthralgia, or rash. Icterus phase, jaundice, painful hepatomegaly, dark colored urine, and pale colored stool. After that, it might vary the clinical symptoms. Some patients experience rapid symptoms improvement, whereas some others may develop a prolonged illness, will show with a slow resolution with a periodic flare-up. Small number of the patient infected with hepatitis B have rapid progression to the disease and can lead to fulminant hepatic failure over a few days to weeks. The risk of acute hepatitis B to progress to chronic is age dependent, so more than 90% of neonates and infant, 25% to 50% of children age 1 to 5, and less than 5% of older children. Most people with the chronic hepatitis B infection are asymptomatic and have no evidence of liver disease. 15 to 40% of people with the chronic infection will, however, develop liver cirrhosis, hepatocellular carcinoma, or liver failure, and 25% chronically infected people will die prematurely from those complications. Treatment for acute infection. The diagnosis of acute hepatitis B infection is based upon detection of hepatitis B surface antigen and immunoglobulin IgM antibodies to hepatitis B core antigen antibodies. Treatment for the acute phase is upon the clinical setting. However, appropriate measurement should be taken to prevent the infection in all exposed contacts. So hepatitis B immunoglobulin and hepatitis B vaccine should be administered to all household and sexual contacts who are not known to be immune or infected. For most patients, treatment is mainly supportive. The likelihood of acute liver failure from acute hepatitis B is less than 1%, an immunocompetent adult, and the likelihood to progress to chronic infected is less than 5%. So the patient with a severe protracted course, such as those who develop a coagulopathy, international normalized ratio more than 1.5, or those with the persistent symptoms or marked jaundice for more than 4 weeks after presentation should be treated. Also, patients with acute liver failure, coagulopathy, and encephalopathy due to hepatitis B infection should be treated also to reduce the likelihood of reinfection post-liver transplant should a liver transplant become necessary. So for the patient who might need a liver transplant should also be treated for hepatitis B. Also, for those who require treatment, tenofovir or entecavir monotherapy is preferred. Interferon should be avoided because of the risk of bacterial infection and a further increase of hepatic necroinflammation in patients with a severe hepatitis or acute liver failure. Treatment can be stopped after confirmation that the patient has a cleared hepatitis B surface antigen, 2 consecutive tests 4 weeks apart. Treatment for chronic infection. The diagnosis of chronic hepatitis B infection is based upon the persistence of hepatitis B surface antigen for greater than 6 months. The initial evaluation of patients with the chronic hepatitis B infection should include a history and physical examination emphasizing risk factors for co-infection with hepatitis C virus, hepatitis delta virus, and or HIV. Use of alcohol, family history of hepatitis B infection, and hepatocellular carcinoma. Should also do the laboratory tests and evaluate for other causes of liver disease, such as hemochromatosis, hepatitis C, and hepatitis D. Screening for HIV, and also screening for liver cirrhosis. The decision to initiate treatment for hepatitis B is primarily based upon the presence and absence of cirrhosis, ALT level, and hepatitis B DNA level. Therapy may also be indicated for those who have certain concurrent conditions, pregnancy requiring immunosuppressive therapy, and risk factors such as hepatocellular carcinoma, age more than 40, or family history of hepatocellular carcinoma. Treatment. The treatment differ if the patient has cirrhosis or doesn't have cirrhosis, and these are the treatments for patients who are not pregnant. So patient without cirrhosis in non-pregnant adult, hepatitis B antigen is positive, and hepatitis B PCR more than 20,000, and the ALT less than 2 times of the upper normal limit. Treatment is not required because the current treatment has low efficacy in inducing hepatitis E antigen seroconversion. Treatment may be considered in older patients, more than 40, or those with a family history of hepatocellular carcinoma. Patients should be monitored, and the treatment considered if ALT becomes elevated more than 2 times upper limit. Liver biopsy shows moderate to severe inflammation or fibrosis, and or non-invasive testing just suggests moderate to severe fibrosis. For patients who have hepatitis B E antigen positive and they have the DNA PCR more than 20,000 and the international more than 20,000 international units per ml, or ALT more than 2 times of the upper limit, we should observe for 3 to 6 months if compensated, and treat if no spontaneous recovery happened. Now, entecavir, tenofovir, and tenofovir afenamide and tenofovir disoproxil or interferon alpha are preferred for initial therapy. And point of treatment when the seroconversion from hepatitis B antigen to antibody happened. Duration of therapy. The interferon alpha about 48 weeks. Entecavir and tenofovir is about at least 12 months after the seroconversion happened. Now, if the hepatitis B antigen is negative and the PCR more than 20,000 and ALT more than 2 times of the upper limit, or the liver biopsy shows moderate to severe necroinflammation or significant fibrosis, or non-invasive testing shows significant fibrosis, then we can start one of these treatments, entecavir, tenofovir, or pegylated interferon alpha. Now, the preferred is initial therapy is one of them, and the endpoint is when we have loss of the antigen of the surface. Duration of this therapy for pegylated interferon alpha is about 1 year, and entecavir, tenofovir is about several years or indefinite. Now, if the hepatitis B antigen is negative and the hepatitis B viral DNA is less than 2,000 and the ALT less than upper limit, then monitor and to treat only if the hepatitis B DNA and ALT increase as described above. For the patient with the liver cirrhosis, There are two scenarios. When you have the hepatitis B E antigen is positive or negative, and the DNA is detectable, and the ALT at any level, or if the hepatitis B antigen is positive or negative and the PCR is undetectable and ALT is at any value. So in the first scenario, if the patient is compensated, we treat with entecavir, tenofovir, or tenofovir, yes, and treatment should be continued indefinitely. Decompensated patient, we treat immediately regardless of ALT and the DNA level, entecavir or tenofovir preferred. And then maybe we'll refer to liver transplant. For the second case, if they're compensated, observe and recheck the DNA during the follow-up and reevaluate. And if they are decompensated, then refer to a liver transplant, recheck DNA during the follow-up, and evaluate for other causes of cirrhosis as well. Vaccination, hepatitis B vaccines are administered either 2 doses series at 0 and 1 month, or a 3 doses series. More than 90% of healthy people achieve immunity after completion of the vaccination series, 0, 1, and 6 months. Serology testing and booster vaccinations are not recommended before travel for immunocompetent adults who have been previously vaccinated. Consider post-vaccination serologic testing for healthcare personnel, public safety workers, those who require or might require outpatient hemodialysis, HIV-infected people, sex partners of hepatitis B surface antigen positive, and people and other immunocompromised people. Now we'll move to hepatitis C. Hepatitis C RNA virus and is a member of Flaviviridae family with one serotype, but at least 6 major genotypes and more than 80 subtypes. Transmission can be parenteral, perinatal, sexual. However, sexual and perinatal transmission is not very common, or it's not as common as in hepatitis B. Hepatitis C can cause both acute and chronic hepatitis. The acute process is self-limited, rarely causes hepatic failure, and usually leads to chronic infection. Chronic infection after follows a progression course over many years and can ultimately result in cirrhosis, hepatocellular carcinoma, and lead to liver transplant. Approximately 50 to 85% of causes develop chronic hepatitis. Transmission, it's going to be similar to hepatitis B infection, sharing needles, being in direct contact with infected blood, getting needle stick, having sex with infected person, or in touch with the blood products or antibody fluid. The prevalence is 0.5% to 2% of population around the world, with IV drug users and hemophilus being the most commonly affected. However, with safer screening and viral elimination techniques for blood transfusion, the incidence of transfusion-associated hepatitis C infection is decreasing. Approximately 71 million people globally have chronic hepatitis C infection and accounts for close to 400,000 deaths per year. In the United States, we have about 50,300 new hepatitis C infections were diagnosed in 2018, and estimated 2.4 million people have a chronic hepatitis C infection. Incubation period is about 8 weeks. Symptoms: anorexia, malaise, and fatigue. However, 80% of patients remain asymptomatic and does not develop jaundice. The screening, routine one-time screening for adult recommended. Initiate testing, antibody tests. Several different antibodies tests are available, including laboratory tests, immunoassay, rapid point of care tests, and home-based tests. A reactive or indeterminate equivalent antibody test should be followed by hepatitis C RNA testing. If hepatitis C RNA is detected, the diagnosis of hepatitis C infection is confirmed. If the hepatitis C RNA is not detected, then reactive antibody likely represents either past hepatitis C infection or subsequently was cleared a false positive antibody test. Now, for acute hepatitis C, the acute refers to first 6 months of hepatitis C infection following presumed hepatitis C exposure. Most patients asymptomatic. Symptomatic patients may experience jaundice, nausea, dark urine, and dark urine. Laboratory findings is aminotransferase can be highly variable. However, levels are other than greater than 10 to 20 times the upper limit. Now, how to diagnose or diagnostic tests for hepatitis C? You can obtain hepatitis C RNA by PCR and antibody hepatitis C testing by ELISA. Now, if the hepatitis C RNA is positive and hepatitis C antibody is negative, this is acute hepatitis C infection is likely. A detectable hepatitis C RNA in the setting of undetectable antibodies that subsequently become detectable within the 12 weeks is generally considered as a definite proof of acute hepatitis C infection. Now, if you test and you find that hepatitis C RNA positive and hepatitis C antibody is positive too, now confirm that infection, however, cannot be distinguished between acute and the chronic infection. If there is documentation of a serum sample within the prior 6 months with a negative hepatitis C RNA and anti-hepatitis C antibodies, then this is an acute. Repeat hepatitis C RNA testing at least 6 weeks later might help distinguish between acute and chronic. Spontaneous viral clearance, check for hepatitis C RNA at 12 weeks following exposure or following diagnosis if the infection date is unknown. Negative hepatitis C RNA at this time point is spontaneous clearance. Now, estimates of the frequency of spontaneous viral clearance vary from 14 to 50%. More recent studies of acute hepatitis C infection report higher rates of spontaneous viral clearance and some as high as 50% clearance. For most patients, we suggest antiviral treatment during acute infection rather than waiting 6 months until chronic infection is established. For those who prefer to reduce the risk of unnecessary treatment, start the treatment once detectable hepatitis C RNA is documented 12 weeks following the estimated date of infection. The goal is to eradicate hepatitis C RNA, which is associated with decreases in all-cause mortality, liver-related death, need for liver transplant, hepatocellular carcinoma rate, and liver-related complications. Now, the treatment algorithm for hepatitis C. If the patient has a clinical signs or symptoms such as decompensated liver cirrhosis, those include ascites, encephalopathy, jaundice, and varicocele. Antiviral therapy should only be undertaken in consultation with an expert in hepatitis C treatment, ideally at a transplant center. If they don't have these symptoms, then is the following information available or can be ready checked, like hepatitis C genotype and non-invasive measure of fibrosis? If yes, then does the patient have a genotype 3 infection or cirrhosis? And if the answer is yes, then select one of these regimens. And if the answer is no or cannot obtain the hepatitis C genotype or non-invasive measure of fibrosis, then select one of the following regimens, which is sofosbuvir or glecaprevir.
Yeah. Mm-hmm.
If the answer is no.
Okay.
RNA virus and a single species. Hepatitis D is an RNA virus and a single species in the Delta virus family. It contains the hepatitis D antigen and DNA strand and requires the presence and help of the hepatitis B virus to replicate. It uses hepatitis B surface antigen as it develops protein. Therefore, those who are infected with hepatitis D virus also have co-infection with hepatitis B virus as well. Hepatitis D has modes of transmission similar to hepatitis B, but Perinatal transmission is uncommon. Simultaneous infection with hepatitis B and D have a self-limited infection. Symptoms are similar to acute hepatitis B infection. Chronic hepatitis B virus carrier who develop superinfection with hepatitis D tend to be more severe acute hepatitis, and the majority of these patients will develop chronic hepatitis D infection. Chronic infection with both hepatitis B and D can lead to fulminant liver failure, severe chronic active hepatitis, and progression to cirrhosis in a majority of patients compared to those patients who only have chronic hepatitis B infection.
So this is, again, one of the testable points. I mean, hepatitis, if you ask me for test questions, it is very difficult to do. And this scenario, like they will want you to know that superinfection, can cause fulminant liver failure is one scenario that is possibly that can be tested. The other, when I think about hepatitis, I think about it as acute versus chronic. Chronic, the main things would be they will be asking, maybe some guidelines or anything. For acute hepatitis, you have to think about other than hepatitis viruses, the other causes of hepatitis too. You have to be thinking about it. If it's a traveler, you have to think about malaria. Then there is another scenario, like they will give you whitewater rafting in Costa Rica or triathlon. And those scenarios, you have to be thinking about leptospirosis. Drug-related hepatitis is also common, that, augmentin that can cause hepatitis. Then, syphilis, secondary syphilis, the ALK phos will be very high for those type of scenario with hepatitis. And then non-infectious hepatitis also has to be, we have to be thinking about that. In pregnant patients, HELP syndrome, and those are some of the scenarios. But anyway, back to your slides. Yeah. Mm-hmm.
Hepatitis E, non-enveloped RNA virus and a single species. The primary transmission mode of hepatitis E is the fecal-oral route, contaminated water, most common source of infection. Person-to-person transmission is rare. However, occasionally maternal neonatal transmission may occur. Patient with acute hepatitis E infection develop an acute self-limited illness and similar to hepatitis A infection. Fulminant hepatic failure is very rare. Patients with hepatitis E infection who are pregnant have a higher mortality rate. Okay. Human piggy virus. This virus is common global infection and with a worldwide prevalence of around 3%. Detectable in all ethnicities, and researchers believe that 1 to 4% of blood donors worldwide are carrier of this virus. The general understanding of that is that around 25% of global population are carrier of antibodies to this virus. Infected blood products increase the prevalence of this virus. Routine blood screening of donation of blood that infected is not done, presumably due to the lack of evidence of causing disease. Co-infection is common, approximately 10 to 20% of adults with a chronic, either B or C infection. Clinical symptoms is most patients are asymptomatic, and there have been few reports fulminant and chronic hepatitis, as well as hepatic fibrosis as well. The patient may, the patient may have also elevation of ALK phos and gamma glutamyl transferase, but patient infected with this virus, normal liver functions are normally tested. Now, we have a couple of questions regarding viral hepatitis from MixUp. The first question is a 22-year-old man is evaluated in the office for hepatitis A virus exposure that occurred 5 days ago. The source of the exposure is the patient's college roommate who is now at home recovering from the illness. The patient's mother has confirmed he has never been vaccinated against hepatitis A. Now, on physical examination, the vital signs and other findings are normal. Which of the following is the most appropriate preventive measures? Hepatitis A virus vaccine, B, hepatitis A immunoglobulin, C, hepatitis A vaccine and immunoglobulin, or no preventive measures. So the answer is A. Non-immune persons exposed to hepatitis A virus should receive post-exposure prophylaxis with hepatitis A vaccine as soon as possible after exposure. Post-exposure prophylaxis with both hepatitis A vaccine and immunoglobulin may be considered for non-immune patient older than 40 years old.
Okay, great. We have 2 minutes left. Yeah.
The next question is 29 years old woman is evaluated routine follow-up for chronic hepatitis B virus infection. She's asymptomatic, has no other medical conditions, and does not take any medication. She is negative for hepatitis C virus infection and HIV. On physical examinations, these are the labs results. And the question is, which of the following the most appropriate management? Antiviral therapy or clinical management? The answer is antiviral therapy. And the last question is 58-year-old woman evaluated treatment for hepatitis C virus. She has unresectable metastatic pancreatic adenocarcinoma and requested treatment for hepatitis C. Which of the following is the most appropriate management? The answer is no further hepatitis C related testing because the patient has a limited lifetime expectancy and doesn't need any meet criteria for hepatitis C treatment.
Okay.
Thank you.
Excellent. This is a great presentation, Lean, and this is wonderful. And thank you for joining.
Thank you. Thank you so much, Dr. Gopal.
Okay. Bye.
Bye. Have a good night.
To you.
Thank you.